Well, good morning, everyone. It's wonderful to see you here. My name is Vivian Lee, and I'm responsible for the Health Sciences campus of the University of Utah, as well as the healthcare delivery system and the health plan. I also happen to be the dean of the medical school, and as somebody surrounded by pre-meds and former pre-meds, I somehow felt impelled to start with a multiple choice question this morning. Patients are to providers as milk is to grapefruit, H2 is to O, Dennis Rodman is to North Korea. Well, I think we all hope that patients are to providers. We do better than Dennis Rodman did in North Korea. In fact, I hope we're better than Dennis Rodman and North Korea. But I think we all recognize that we have a ways to go before we're as tight as H2O. And so what I'd like to do this morning is to talk with you a little bit about how we can build better partnerships between patients and providers, and how that partnership is absolutely essential to the transformation of healthcare that we all understand we need to undergo. It's often good to start with your take-home message, and I think in modern parlance that might be your tweet. So here's what I'd like to say overall this morning. I'd like to talk about healthcare transformation essentially depending on three components: data, transparency of that data, and physician and patient engagement. This is our formula, this is our algorithm, and this is I'm going to share with you today two examples of how this has worked at the University of Utah. These two examples, one of them dates back a little bit longer. We have a longer history, and I can tell you a little bit more about the outcomes. And the second example in the story I'm going to tell you has a little bit of a shorter history, and we're well underway right now. So the first part starts about 7 years ago when my predecessor, Loris Betts, the senior vice president at the University of Utah, just got fed up. He was just fed up with patient complaints, with letters complaining about the attitudes of people that had interacted with them, and he was fed up because his wife came into the system and didn't receive the best treatment either. At that time, the University of Utah was ranked about 18th percentile. We were in the bottom 5th in the country in patient satisfaction. And so Loris launched an initiative called the Exceptional Patient Experience, because he said you can't have a great medical center if your patients don't think you're great. Now, the first step in the exceptional patient experience journey, as you can imagine from the algorithm that I shared with you, was data. We didn't have very good data, so we decided to partner with Press Ganey in order to come up with patient survey questions that we could benchmark against national references. And we took great care in coming up with the questions that we wanted to ask all of our patients, whether they were inpatients or outpatients. Now, within 24 hours of being seen at the university, they received this questionnaire. And these 10 simple questions, which are scored from 1 to 5, focus on a couple of key areas that we really wanted to emphasize in terms of the exceptional patient experience. And they were professionalism, they were communication. How well, for example, do you understand the medications? Do you understand the follow-up care? And they were patient engagement. How involved were you in the decision-making? I want to emphasize that that was the nature of our questions, because the questions that we asked really incentivized and motivated behavior change among our providers. And we specifically did not ask, did your physician do whatever you asked for? Did you get the prescriptions that you wanted to? Did you get the labs that you wanted? We didn't ask that. We really focused on professionalism, on engagement, and on communication. Because these are benchmarked, we were able to translate this into dashboards for our providers that look like this. And this is a typical result from a new cardiologist who joined the University of Utah in 2011. And these numbers reflect their national percentiles for each of these questions. And you can see that these were color-coded because we set some internal targets for all of our providers. And for this particular cardiologist, when they first joined the organization, their percentiles were in the 20s to 30s, and they obviously didn't meet the criteria that we had set. And so we partnered them with other providers across the system who had developed best practices, and we even had SWAT teams who would come in and work with the providers on some of the most common challenges that we faced, including wait times and including providers tending to focus a lot on their computers and EMRs and not looking at patients and on communications. A lot of those themes were really common across the entire enterprise. And the pattern that we saw consistently in working with these individuals who were very motivated to change was very similar to this. So after a couple of years with that feedback, with the data constantly coming back from the patients, we see this consistent increase in patient satisfaction. We focused a lot on transparency first at the individual level, so we provided these data privately to the providers, and then with notice, we gradually expanded the scope of that transparency. So next, you could see where you stood across your peers of other cardiologists, and then we let cardiologists compare themselves with rheumatologists and orthopedic surgeon. And then finally, we took the step about 2 years ago of pushing transparency to the next level. And that was making our patient satisfaction data fully transparent online. So if you go to our website, we have a Find a Doc website, just like most medical centers do. If you click on that Find a Doc website, you come to a page where you can enter the name of a specialist or try to search for a provider. In this case, for example, if I'm looking up one of our general surgeons, Courtney Scaife, you'll see her typical bio page with the contact information. And then in the upper right-hand corner there, you see those familiar 5 stars. Just like on Amazon, just like on TripAdvisor, except for these 5 stars happen to correspond to the patient satisfaction scores that this provider has received. In addition, you can actually go down, scroll down on the page, and you can see their individual scores for each of the questions that we ask the patients, and we include all the patient comments, unfiltered, online. We posted this about 2 years ago. We were the first in the country to do this, and there were some really intended and unintended consequences. First of all, we saw our traffic to the website increase significantly, increased by about 50% just in the first 3 months. Secondly, an unexpected consequence was that it significantly benefited our search engine optimization. So because we were feeding real-time data all the time that was real patient data, now our physicians pop right up when you Google or you Bing them, however you search for a provider in Salt Lake City area. So that was a real benefit for our providers. And then, of course, it significantly added motivation to our providers to continue to improve in their effort to enhance the patient experience. So in the last round of data, again benchmarked nationally, we were very pleased to find that 46% of our providers, about 1/2, are now in the top 10 percentile in the country. And 1 out of every 4, or 25% of our providers, are now in the top 1 percentile. Overall, system-wide, we moved from being the bottom 18% to in the top 10% in the country in just a few short years. So even we in academic medical center can change if we have data, if we have transparency, and if we have patient and provider engagement. Now that's the first part of the story, and the second part of the story moves us into the next phase of the value equation. So most of us in healthcare know that we're really focused on transforming from volume to value, and while we've concentrated a lot so far in this conversation on service, as an institution, we also care a lot about high quality and outcomes at reasonable costs. And that begins the second part of my story. At the University of Utah, we have been focusing for many years, as most institutions have, on quality. And while we've seen our patient satisfaction scores go up, we've also seen our quality go up. All academic medical centers, all university hospitals in the country are ranked every year by University Health System Consortium. In 2010, the University of Utah was ranked #1 in the country, and for the last 4 years in a row, we've been in the top 10 now of over 140 teaching hospitals in the country. But what about the cost side? So like most other medical centers in the country, if not all medical centers in the country, we really struggle to understand the costs, what it really costs us to provide care. And I'm not talking about charges. Most of you are aware of all the controversy in the lay press about charges. Why can't I figure out how much a hip replacement costs or a CABG costs? I'm talking about, from a business perspective, the true costs of delivering care, the true costs of running our business. And I would put forward to you that there is no system in the country that fully understands its costs. Many people do estimates, they do charge to cost ratios, but they don't actually know our costs. And I think that is the hidden deep dark secret of why our healthcare system from a financial perspective is so broken. So we undertook about a couple of years ago to really understand our cost of care so that we could map what outcomes our patients were achieving, what service we were able to deliver at what costs. And in order to do that, we had to integrate data from all kinds of systems throughout, including our electronic data warehouse, as well as financial feeds, lots of data feeding into this. And we created a tool which we call value-driven outcomes. And the value-driven outcomes tool is very accessible for providers, for providing teams, and for administrators like me to drop down, click, and look at our costs against our outcomes. So I wanted to just show you one screenshot among the many different screens that are available for this tool that shows you the average cost per visit. And in this case, for orthopedic surgeons, and I've selected the DRG that is for total joint replacements. But of course, I could be querying anything in our system. But I just, for this example, picked orthopedic surgeons doing total joint replacements. And what you see here are the average costs for each of our 10 orthopedic surgeons to do a total joint replacement. Not what we charge, because the charges are relatively consistent by payer, but what it actually costs us to do it. And even from the back of the room, you can see that there's a significant amount of variability. And what's causing that variability is illustrated in the different color coding. So the biggest driver of variability is the yellow bars, which is the cost of the prosthesis itself, the supplies. But even the smaller columns, even the smaller bars, the thinner bars are quite variable. And they may be labs, they may be imaging tests, they may be length of stay, they may be operating room time. There's a significant amount of variability here. Now, if you take a bunch of orthopedic surgeons and you put them in a room together, remember, they're all former pre-meds. What do you think they feel when they see this? They're immediately intensely competitive. Hey, Sally, how come you're 3 times the cost of Bob over there? Very, very interesting motivating factor. So the next key to that engagement is actually a step in education. It's a little bit harder to address the care pathways that are needed to be addressed in order to tackle this problem than was for the exceptional patient experience. And so we decided to do a system-wide training program for lean and process improvement across our entire enterprise. Been doing that for about 2.5 years. And so these orthopedic surgeons now, equipped with some knowledge about how to do process improvement and partnering with some value engineers, were able to focus on the first step of their journey, which is to challenge us in terms of whether we were measuring outcomes fairly for them and whether we were taking into account severity of illness, complication of the patients, and so on. And so they came up with a perfect care index of 7 outcomes measures that they felt were the most important, including things that we were getting paid for, like CMS core measures, as well as one that they felt was the most important, which was early mobility. Each of these lines corresponds to a different patient that was cared for, and with this dashboard, very similar to the exceptional patient experience dashboard, they could readily see where we were falling short, where we had some challenges. And so the bar that has the red in it is the early mobility score. So when this team went back and looked to see what was happening, why so many of our patients were not getting up and out of bed after their total joint replacement, it turns out the story was very simple. The patients who were coming out of the operating room in the afternoon, after the physical therapy therapists had left and ended their shifts, were not getting up and out of bed the first day. So we split those physical therapists into 2 shifts. Now everybody gets up and out of bed on the first day out of surgery. Length of stay is shortened, complications are shorter, patient satisfaction is improved. In this relentless journey towards better outcomes, as shown in the blue graph on this perfect care index, the blue line shows that in the last year we've significantly improved our patient care in terms of quality. We see a significant drop in costs, 30% decrease in our actual costs of delivering a total joint care. How does this roll up across the system? Well, we see this pattern consistently as we improve quality, as we address patient satisfaction and patient engagement, we see costs come down. And so in my second to last slide, I just want to show you that we, even in academic medicine, are able to bend the cost curve. Here are the data over the last 4 years for the total expense per case mix adjusted discharge. So it's basically total expense per discharge adjusted for the severity of the patient's disease. And you can see in the white line, U.S. healthcare inflation growing at about 3.5% over this time period. And the University of Utah, our rate of increase has been 1.4%, so 2 full percentage points below U.S. inflation. So it is possible to bend the cost curve. It's possible to do it with better outcomes, better satisfaction. And our formula is data, transparency, and physician and patient engagement. So I hope if you'd like to learn more about it and share your own experiences that you'll come to our website, Algorithms for Innovation. And I'm really, really grateful for your attention. Thank you.